diseases, while these granulocytes elevate in bacterial diseases. Of the granulocytes, the eosinophils is important because it can be tested, elevate in allergic reactions. So any person with an allergic condition like asthma, for example, is expected to have an elevation of the eosinophils. And from time to time, they can, ask you those concepts. Um, the neutropenia is considered critical and requiring neutropenic precaution initiation when the absolute count of only the neutrophils, okay, only the neutrophils is below 500, okay, below 500. Okay, so this is the most important that I remember could be tested in case of test of the blood of the blood. Remember that when the question is about anemia, there are two main type of deficiency anemia: the deficiency of iron and deficiency of folic acid, and or B12. B12. In both, the amount of red blood cells is low and the amount of hemoglobin is low. But the aspect of the red blood cell in the iron deficiency is small red blood cells, while the few red blood cells that are left in the B12 deficiency is big red blood cells. So it is a microcytic, okay, anemia, and this is a macrocytic anemia. Is a big difference in the size of the red blood cells between one and the other, okay? And can be also be tested because it can be identified in the microscope easily to differentiate the type of anemia. The the platelet count um, goes from 150 to 450,000. The important to remember is this value, because the problem with the platelets is mainly when it's low. It's very rare that have high platelets and risk for thrombosis, for clots. Uh, is not common. So the most common problem is that the person has a problem that lowers the count of platelets. The platelets can be low because the bone marrow is sick, or the platelets can be low when there are antibodies that destroy the platelet. Of course, if there are antibodies destroy the platelets, it's an autoimmune disease. And this condition is called idiopathic thrombocytopenic purpura, and is an autoimmune disease, more frequent in women as usual in young women, that can lower significantly the amount of platelet because the antibodies destroy the platelet. An important cause of low platelet is also an immunological phenomenon. It's not autoimmune, but it's an immunological phenomenon uh, induced by a medication, by the heparin. Heparin in any form can produce in few people, it's not common, it's strange, but it's an idiosyncratic reaction, can produce antibodies that destroy the platelet. Heparin in some people, not in everybody, in some people can induce the production of antibody that destroy the platelets. And it is called heparin-induced thrombocytopenia. And it's very severe, it's very bad, is very, very, very critical. And the test, the Nclex, give a lot of importance that if you have a person receiving heparin and the platelets are slightly low, so it's are in 145,000, which is slightly low, even this little reduction of the count of platelet is critical because it's a heparin-induced thrombocytopenia, and is uh, an important detail to remember before the test. But platelets also have a critical value. A critical value is considered below 20,000. You can have platelets in 50,000, which is very low. But if you don't have trauma, you don't bleed. But when you have the platelets below 20,000, you can start bleeding without any trauma, even in the brain, which is the most serious. So if you have a person with low platelets, but is more than 20,000, what you do is to initiate bleeding precaution. And the most important bleeding precaution, Nclex question, is don't allow the patient to have a trauma. So reduce it to the maximum the possibility of falling or having any kind of trauma. So obviously you are going to be very careful if the person is an adult to avoid falls. If a person is young, to avoid contact sports and any kind of activity that can cause trauma. But if the person has less than 20,000, is when they need to transfuse platelets, platelets, because they can bleed spontaneously. So remember that the most common problem with the platelet. Uh, the the coagulation tests are always present, and most of you know those coagulation tests, but some of you get confused in the test. So you know that we have two main coagulation tests to memorize: the activated partial thromboplastin time, or PTT, and the prothrombin time, that always need to be paired with the international normalized ratio, or INR. You don't need to learn all those names. You can learn PTT, you can learn PT and INR. It's enough to understand the question and to pass the question. So you know that the PTT is one test of coagulation that evaluates one part of the process of the coagulation, the intrinsic via is called, and the common via. And it's very useful for the evaluation of the dose and activity of the heparin. Okay, this is a mnemonic. If you have bad memory, it's a mnemonic. Okay, if you write heparin, the word heparin, no, the word heparin. Okay, heparin. Okay, heparin. Okay, put a P before the H, and then extend a little, and then you have PTT. It's a mnemonic for the people who have bad memory and get confused in the test, and do that if you want it. And the prothrombin time, the most important is the value of the INR, or the value of the INR. It is measuring the extrinsic via, and especially is measuring the action of the warfarin. So PT and INR for warfarin, and the PTT for heparin. And it's important. Um, the the dose of heparin must be adjusted depending on this PTT. The dose of heparin that is administered basically IV, the regular heparin, the unfractioned heparin, and can be given more or less doses depending of the value of the PTT. The PTT should be, the time that represents the PTT should be prolonged with the administration of heparin to thin the blood. So if a normal that is not receiving, if a person that is not receiving heparin coagulate with this test in 30 seconds, for example, because around 30 seconds is the normal. So probably yours and mine, we are not receiving heparin. Our PTT, our normal PTT, probably is around 30 seconds. Not exactly. Some could be 26, some could be 34, but notice that is moving around 30. Okay, so you can memorize 30 seconds, and then you have an idea of the normal PTT, and then you move a little higher, lower. The idea is that if our blood is coagulating in 30 seconds, okay, when you receive heparin, is to duplicate that. In reality, is a little less and a little more than duplicating. In reality, is prolong that 1.5 to 2.5 times. Duplicate times, no? Duplicate is exactly 2 times, yes, 2 times. In reality, the value is 1.5 to 2.5 times. Yeah, but well, if you have bad memory, remember that duplicate. Okay, so if you make I don't know, $50 per day in your job, if they duplicate your salary is 100, no? Okay, so now you know what is duplicate. Duplicate that, and it's more much to have an idea. So duplicate and a little more. A person that has, okay, the PTT in 30 seconds, okay, can go even to 75 seconds because it is exactly twice, twice the twice 0.5, sorry, the 30 seconds. But if the person instead of 30, the normal is 32, it's going to be a little more. So for test purposes, okay, consider around 75 the upper limit of the safety of a person receiving heparin. If you see that this amount of seconds is beyond 80 seconds, the patient is receiving too much heparin, too much dose of heparin, and the risk is they can bleed. Okay, so summarizing, for test purposes, I need to remember that the PTT is the test for the dose of heparin, and the desired outcome is to have the PTT until 75 seconds, more or less. More than 80 seconds is too much, and the patient could bleed. And of course, all the patients receiving heparin are tested from time to time with a CBC to be sure they are not producing this rare and serious complication called the heparin-induced thrombocytopenia. And this is the most important of the testing of heparin. Heparin has a variety, which is called enoxaparin. The enoxaparin is not given in emergencies. It's to prevent enoxaparin. Is to prevent enoxaparin. Okay, is to prevent the formation of clots, and is given subcutaneous. This type of heparin doesn't require testing. Doesn't require this test of PTT. The dose is standardized based in the weight of the client, not based in the PTT. If you have a scenario that you have an order of giving heparin and the patient is receiving X dose intravenous of heparin and the PTT comes in 90 seconds, they are going to ask you what you expect to be done with the dose, increase or decrease. Of course, you need to say decrease because it's too much PTT. Is the interpretation of the PTT. So it's used to adjust, to regulate the dose of the client. You know that if the client, apart of having the PTT more than 80, a part of that is bleeding, you know that need to be stopped the heparin and need to be used the antidote, which is the protamine sulfate. So you are going to have very silly question in Nclex that, okay, the doctor admitted a patient with GI bleeding, active GI bleeding, and orders enoxaparin to prevent DVT. Then you need to object. You need to call the doctor because you need to question. You need to question the the prescription because you cannot use anticoagulants in a person that is bleeding actively. Okay, so this time of questions are the one that I see related with the heparin. In relation with the PT and INR, remember that is measuring the extrinsic via that are the coagulation factors depending on the vitamin K. And the vitamin K is antagonized or inhibited by the warfarin. As a consequence, uh, the dose of the warfarin is is regulated with the PT and INR. The PT is not seen by the provider because it's too variable, and generally the normal value is around this, no more than 12 to 14 seconds. But the laboratory is going to use the PT to calculate the INR, the International Normalized Ratio. And this is the one that the doctor is going to be seeing. You need to know that a normal person that is not is not taking warfarin, okay, has an INR around 1, okay, 0.6 to 1.2, okay. So your INR probably is 1, around 1, yes. But if the person start taking warfarin, this INR in 1 must be prolonged between 2 to 3. Can be 2.5, can 2.4, 2.9, 3. No lower than 2, no higher than 3. And if it is lower than 2, the dose of warfarin need to be increased. It is more than 3, the dose of warfarin should be reduced. We know that when the person, apart of having an INR in 5, which is high, is bleeding, a part of stopping the warfarin, you anticipate the antidote, which is the vitamin K. But remember, the vitamin K in the test is called phytonadione. Okay, so this is the same of vitamin K. Okay, it's the same as vitamin K. Okay, phytonadione is the active vitamin K. Okay, it's the same. Remember that in both situations, if a person has a toxicity by heparin or by warfarin, can be used fresh frozen plasma, which is the plasma of a person that is healthy and donated blood and is not receiving heparin, neither heparin nor warfarin. And the plasma is frozen to keep active the coagulation factors that this person have in normal amount. And when this fresh frozen plasma is thawed and infused to a person that is having deficiency of coagulation factor because action of the heparin or action of the warfarin, then it is going to be acting very, very, very quickly. Okay. There is another test of coagulation that you need to know, and is the D-dimer. The D-dimer is a test, a blood test that becomes positive only when a person has a clot in some part of the body. And for example, a person with a DVT, a person with a pulmonary embolism, a person with any kind of clotting in the body will develop a positive D-dimer. And this is the application of this test. Is the application of this test. No question in this topic. This slide. Okay. The glycosylated hemoglobin is an average of all the glucose levels of a person in a period of around 3 months. It's a classical question in your English. Okay, so is a period of 3 months. Okay, 3 months. Oh Lord, started misbehaving the program. Okay, and I'm going to make a little change, guys. Just a second. Discord. I'm going to move to record from present slide. Aside from current slide. Okay. Okay, it is better. So the hemoglobin, pardon, the glycosylated hemoglobin, okay, is giving you the level of blood sugar in a person in a period 3 months. 3 months. 3 months. It is very useful because it's better, is much better than testing the glucose in one moment. That could be high or low or normal, but is not reflecting what happens in the rest of the time, in the rest of the 3 months. So if you have a question that is frequent, the Nclex, in which they say which laboratory test you need to report immediately, okay, and you have an A1C very high in 18, which is it's outrageous, okay, because the normal is less than 7, okay, you don't report this as a priority because what has been happening in 3 months back cannot be the priority today. So don't fall in this trap, in this distractor. Trying to find, if it is one option, try to find in B, C, or D option another laboratory alteration that is more acute and means a priority, a more immediate priority. So it is important. It's the best test to know how well or how bad the patient is controlled. And the American Diabetes Association says that diabetic clients should have this below 7%. People that keeps that below 7% probably will not have those horrible complications, vascular and neurological, etc., complications that have the patient with diabetes. The BMP-B natriuretic peptide is a blood test that elevates when the person has heart failure. So the application of the BMP for diagnose is heart failure. If the value of the BMP is below 100, the patient cannot have heart failure. It's not having heart failure. Okay, it's the main application of the BMP. The questions that are seen about BMPs are very simple, and just to understand that it's for heart failure, in that a person have less than 100 is not having heart failure. Amylase and lipase are two tests to diagnose pancreatitis. These two tests elevate when a person has a pancreatitis. You know what is pancreatitis, and the other test that is done together with this is the abdominal CT scan to see the pancreas, the inflammation of the pancreas. Ultrasound is not useful to diagnose pancreatitis, and it's expected that in pancreatitis you are going to have an elevation of the blood sugar and elevation of the white blood cells concomitant to the elevation of the amylase and lipase. The prostatic specific antigen, or PSA, is a test that tends to elevate significantly when there is prostate cancer. But it's very important in the classical question that you have in the Nclex, the same that have been taught in the school, that if the patient needs to have an evaluation of the prostate, requires two tests, the PSA and the digital rectal examination or rectal ultrasound. The rectal digital examination or the rectal ultrasound elevates the PSA. So first you draw the blood, and then the patient go to the doctor for a rectal digital examination or the rectal ultrasound. Of the liver function test, of course, the AST, ALT are the most common, done. And because the normal values are difficult to remember, my suggestion for test purposes is keep below 40 for both. Because if they are elevated, like in a hepatitis, like in liver toxicity by statins, et cetera, is going to be in the orders of the hundreds and the thousands. Yeah. So it's easy. It's easy to remember this value of 50, 50, 50. That should be below that. Bilirubin, the importance of the value of the bilirubin to remember is that in adults is around 1, okay, 1.5, yes. But in newborns, the bilirubin normally is high, okay, is high, okay? So the bilirubin can be as high as 12 milligrams, and it's totally normal, okay? Elevation above 18 milligrams are critical in newborns, okay? In this interval between 12 and 18, phototherapy tends to be enough. And if there is more than 18, more interventions are done. We studied that in OB. It's important to remember that when the bilirubin elevates before the first 24 hours is the bilirubin that need to be reported as a priority because it's the pathological. The elevation of bilirubin that occurs later after the first 24 hours, okay, are less has less bad prognosis as the elevation that occurs in the first 24 hours. The classical question, and Nclex is precisely this, okay, the information that you have been acquiring. Remember that bilirubin is the product of the degradation of the hemoglobin. So people that suffer of hemolytic anemia will have an overload of destroyed hemoglobin because the hemolysis, and they develop, jaundice. And remember that bilirubin is excreted by the liver in the bile, and the bilirubin is giving this color of the bile, and the bile is giving the normal color of the feces. The feces are brown because the bile. If for any reason there is an obstruction in the flow of bile from the gallbladder and the liver to the intestine, then the feces are not brown anymore. It's become white, becomes a clay color. Okay. The albumin is also a liver function test, but it's also a test of nutrition at the same time. So the two main causes of a person having low albumin is malnutrition or having a severe liver disease. When we talk about severe liver disease, we're talking about cirrhosis. And the prothrombin time, the test that we just studied that evaluates the extrinsic via of the coagulation and the coagulation factors depending of the vitamin K, remember that those coagulation factors are produced in the liver. So a person that is not taking warfarin, but has a severe liver damage, is going to have an INR in 2.8 or in 3.8, which is prolonged, is high, is prolonged, is too high, without taking warfarin. Is not taking warfarin. Why? Because the liver is damaged. And the coagulation factors, depending on the vitamin K, are synthesized in the liver. If the liver is okay, the liver is normal. The liver is normal, but is inhibited in its function of producing those coagulation factors by the warfarin, then the INR prolongs. But if the patient is not taking warfarin and the INR is prolonged, is because the liver is damaged. So the INR is a liver function test. It is Nclex question. It's something that you need to understand. Guys, if you don't understand anything that I say, stop me and ask me. Okay, and ask me. Serum creatinine, memorize the normal value, 0.5 to 1.2. Why is useful to memorize the upper limit, 1.2? Because in actual question, they place the 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 value in 1.8, in 2.5, and then you need to recognize that it is a elevation, is renal failure. So, for example, the patient has been prescribed lisinopril, and which lab result of this four requires clarification of, questioning the order. You have hemoglobin low, blood sugar high, whatever, and then you have creatinine 1.8, which is high. So you need to recognize that this creatinine is high. And also you need to recognize that in renal failure, you don't use ACE inhibitor because ACE inhibitor elevate potassium, and in renal failure, the potassium elevate, and when the potassium is too high, the people die. Those are the questions you need to apply your knowledge of the normal value of the creatinine. The blood urea nitrogen is parallel with the creatinine, but is less specific because the BUN elevates in dehydration when there is hemoconcentration, something similar to what I explained with the hematocrit. So if a person has normal creatinine, has the creatinine 0.8, and the BUN is high, has the BUN in 30, it is a dehydration. If the person has elevated the creatinine, has 1.8, and has elevation of the BUN, has 30, is a renal failure. This is dehydration, this is renal failure. The cardiac markers, again, the one that is tested always is troponin. The troponin, the value, you don't need to memorize the value. Don't do that. Don't waste your time with that. And the important is that this elevation of the troponin occurs when there is MI. MI. If there is angina without MI, there is no elevation of the troponin. Only when there is a necrosis, when there is infarction, is when the troponin elevate. And it's important that the troponin should go back to normal around 1 week. Okay, around 1 week. If you have a question that is actually that the troponin persists elevated beyond 10 days, is because the patient is having reinfarction, and it's not good. Okay, so if a person enters today with an infarction, this troponin should go back to normal around 1 week. If it is still elevated beyond 10th day, uh, is because the patient is having reinfarction, which is a complication of the infarction and is not good. The muscles of the skeletal muscle, can suffer diseases, can suffer myopathies. Okay, myopathies are diseases of the bones. The two diseases that you need to know, one is called rhabdomyolysis, that you know is something very bad that can occur in many critical conditions. You know that the statins for cholesterol uh, could produce rhabdomyolysis in some people, and you need to monitor that, especially if they consume the statins with grapefruit juice. And it's manifested by muscle pain and muscle weakness. And then the myoglobin of the muscle is going to be eliminating the urine, is producing myoglobinuria. Myoglobin is the protein that is inside the muscle. When the muscle bursts, the myoglobin is released and is excreted in the kidneys. And it's very bad. It's very bad. You know that other conditions like malignant hyperthermia, neuroleptic malignant syndrome, the heat stroke, etc., can also produce rhabdomyolysis. Trauma can produce rhabdomyolysis. Many conditions can produce rhabdomyolysis. In those cases, the diagnosis, a part of the muscle pain and the muscle weakness, is going to be an elevation of the CK, the creatine kinase. But there is a disease, an autoimmune disease, that from time to time is tested. It's called dermatomyositis. It's like the lupus, but instead of, of being so generalized like the lupus, is limited to the muscle. And the muscles are painful and are weak, and also have elevation of the CK. Dermatomyositis has been tested in Nclex. It's like lupus. It's an autoimmune disease, but the muscles are the main victim of the attack. Remember that to diagnose HIV, we do a screening test called ELISA that looks for the presence of antibodies against the virus of the human immune deficiency. The ELISA is a very sensitive test that is very low probability that somebody escapes to this test. But because it's especially so sensitive, requires confirmation because could produce false positive. And if somebody has the ELISA positive, must have a second confirmation test, which is the Western blot. Once a person has the virus, the person starts producing antibodies against the virus. And this is what is detected with the ELISA and Western blot. Those are tests to detect antibodies against certain infections. Not only HIV, are specific for any disease. Once a person has the ELISA confirmed by the Western blot positive, it is positive for the rest of the life. There is no cure yet for that. So there is no need of repeating this test. But now this person is initiated a treatment. Is once it is known that the person has this virus, then an antiviral treatment, an antiretroviral treatment is initiated. Nowadays, this antiretroviral treatment keeps the person healthy and not contagious. And it's important to know that. And the person that we know has the virus is going to be tested regularly to determine if the antiviral treatment is working. Is going to be tested regularly with two tests: the count of a CD4 positive T lymphocyte or T cells and the viral load through polymerase reaction, the PCR. The PCR is a test that can detect if you have how many particles, viral particles you have, and it's called viral load. The person that is responding well to the treatment have a non-detectable viral load, zero viral load. It doesn't mean that doesn't have the virus, has the virus, but is in such a low concentration that cannot be detected by the PCR. PCR is the same test that they do for detecting the presence of the coronavirus in us, no? Okay, but using other antibodies, okay? And the CD4 count, you need to know that any of us have more than 600, okay, cells per cubic milliliter. In patients that have HIV, if the treatment is working, will keep the same normal amount. But if the person is not following the treatment or the treatment is not working, then the CD4 count starts dropping. And when it drops below 200 is when the person starts presenting the opportunistic infections and can die. It's going to develop the AIDS. The syphilis testing is frequently, in the test. You need to know that the syphilis test have a screening test that is very sensitive and known to everybody, called BDRL or RPR, either one. Okay, either one. And this is done for pregnant women, for people that has other sexually transmitted diseases as a routine in many climes. If this test is positive, happens the same as the ELISA, needs to be confirmed with a more specific test called the FTA-ABS, or fluorescent treponema absorption test, which is the confirmation. Both tests have been present in question in your Nclex. For the test of ABEs, you need to know the normal values. If you know the normal value of the ABEs, then you cannot make interpretation of the ABEs. You need to memorize that pH is 735 to 745. The CO2 is the same as the pH minus the 7, 35 to 45, bicarbonate 22 to 26, and the level of oxygen in the blood through ABEs is 80 to 100 millimeters of mercury. Don't confuse this value with the O2 saturation, which is different. You know that to obtain the specimen of blood, you do that from the radial artery. And before piercing the radial artery, you need to verify that the other artery that you have in the wrist is working, is the the ulnar artery. And this test is called Allen test. The test has the following steps. First, you ask the client to make a strong fist, and you make a pressure in the radial and the ulnar artery at the same time. You ask the patient to open the mouth, open the hand, and see that the hand is very pale, extremely pale, it's blanch. And then you release the pressure of the ulnar artery without releasing the pressure in the radial artery. You see here. And you need to see that the hand that was pale becomes now red. If you compare this hand with this hand, it is pale and it is red. If it occurs quickly, let's see, in 6 seconds or less, the ulnar artery is strong, patent, and supplying enough blood flow to the hand. And if something happens in the radial, the hand is going to survive. To obtain the specimen, we use a very fine needle, 26, 28, and then inject a syringe with heparin. Once you obtain the arterial blood, you need to remove any bubble of air. You need to remove that, and you leave the blood in the syringe, and you put that in ice and send to the lab to be tested for the ABGs. Don't forget that you just pierce an artery, and you need to make pressure for a while to prevent the formation of a tumor of blood and hematoma in the region. Okay. You know that these ABGs will allow you to interpret the acid-base balance and also the oxygenation. For the acid-base balance, you only use the pH and the CO2. Well, you use depending of how you learn that. But the people that have problems, and I gave my suggestion is use ROM. ROM. Okay, which is an acronym easy to remember. R means respiratory, M means metabolic, and O means opposite, 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 okay? And E means equal, okay? So it's not difficult to remember that R is respiratory, M is metabolic, O is opposite, and E is equal, okay? So when you see that the pH is low, okay, and the CO2, you only check the CO2 and the pH, and the CO2 is also low, okay, they are equal. They are equal. So the errors that you see, the errors go in the same direction. You say, oh, it is an acidosis, but this acidosis is equal metabolic. It's a metabolic acidosis because the errors are equal. But if you see that the error is not going down, is up, so the CO2 is high, and then what you see, the errors are opposite, 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 then you say, oh, it's the same acidosis. It's the same acidosis, but it is a respiratory acidosis because the O is related with the R and the E with the M, no? It's a respiratory acidosis, no? It's the technique of the ROM acronym. Okay, if you master your pathophysiology and you understand that you don't need to use this trick, no problem with that. But if you want to have a rapid method of knowing if a acidosis or alkalosis is metabolic or respiratory, ROM is going to help you a lot. And of course, for the oxygenation, to memorize that is the normal range. Take care because having an O2 saturation of 80% is critical. Having a PO2 of 80 millimeters of mercury is normal. So don't confuse auto saturation with the levels uh, of oxygens in ABGs because the values are different. If you have any question about this, ask me the question, okay? Just a second. Okay, what came from the school? Okay, no, nothing important. Okay, so this is okay what I can help about this stuff. I assume that there is no problem there because I don't hear any question. Okay, talking about autosaturation, the values are different. And in autosaturation, anything below 90% is critical. Okay, is critical. Frequent question Nclex of the test of autosaturation. What can give you a false autosaturation? A very bright environment light, severe anemia, nail polish or artificial nails, movement, shivering, seizures, or local ischemia where the probe is placed. Remember, the probe can be placed in the forehead, can be placed in the ear lobule, not necessarily need to be placed in the finger. of procedures or diagnostic tests. The GI test, okay, I don't know why, but there are many questions of fecal occult blood in the Nclex, a frequently test. It is a very simple test that can diagnose or can make suspect either GI bleeding as a complication of the treatment with anticoagulant, treatment with NSAIDs, treatment with medication that can produce GI bleeding, or can detect, okay, the initial manifestation of colon cancer, the, the, the third most common cancer in humans, that is, chronic bleeding. And but the bleeding, that is hidden, mixed with the feces, and you don't see the blood. So for that reason, you investigate fecal occult blood. The reactive that is used for the the cheap fecal occult blood is called guaiac. There are other now tests that are immunological tests that are very expensive and can be done, so are more fancy, are more can be charged, okay, more to the insurance, etc. But the guaiac test can be used by a nurse in any doctor's office or any facility, and it's just obtain a specimen, a little microscopic minimum amount of feces, and you add a drop of this reactive, and if changed to blue, it is positive. That's it. But the question that more frequently are tested is how you explain the client that have to eat if they are going to have this test. Because many things that we consume, that we eat, and here is a collage of the stuff to trying to remember, can produce false positive or false negative in the case of the vitamin C of the test. But the most important are the false positive. So any red meat, anything that has red meat, like meatball, for example, sausages, especially blood sausage, okay, can produce a false positive. So 3 days before the test, the person should not eat red meat. And you need to explain that. I seen that as meatballs, as specific, not red meat, not specifically something that you need to know this is made with red meat. Chicken, fish, and pork are allowed. Okay, those are white meats that don't alter the test. The other can produce a false positive, sorry, is the dark green leafy vegetable like broccoli. Broccoli should not be consumed before the test. Turnips, this is turnip. Radishes, this is radish. Okay, and of course taking medication that make you bleed, like aspirin, NSAIDs, and corticosteroid. 3 days before should not be taking that. Also, vitamin C rich fruits and supplements of vitamin C can produce false positive, like oranges and tomatoes, or people that take tablets of vitamin C. And it is tested at a level that apply. For the GI testing, you need to know, because are frequently examined, upper GI series, also called barium swallow. Students have told me that some of them have this as upper GI series, and the majority have the question of this test as a barium swallow. So why is called upper GI? Because the esophagus, the stomach, and the duodenum are the upper part of the GI system. And this test evaluates esophagus, stomach, and duodenum. That's why it's called upper GI. The other is barium swallow. Why? Because the patient need to swallow. They need to swallow barium. Barium is a contrast substance that is introduced in the GI system and stays in the lumen of the GI system, is not absorbed. So the risk of developing an allergic reaction is very low, because it's something that doesn't enter to the blood. You understand? Like the iodine, etc. the barium fills the cavity, and when the X-ray is done, the cavity is seen white, as you see here, because it's filled with the barium. And of course, a person that is going to have a barium swallow must be a person able to swallow. So obviously, it's a person that can be swallowed. If the person can swallow, do you think that this test needs anesthesia in the throat? Obviously, no. The endoscopy, yes, need anesthesia in the throat because they are going to introduce a tube that is going to be very uncomfortable. You need anesthesia, local anesthesia in the throat. But to swallow barium, they cannot give you anesthesia, none in the throat, because then you cannot swallow. It's evident, no? And the person is going to be conscious, so it's not going to be sedated, and this is not painful. Swallowing barium is not painful. To understand bien what is that. And the person will have X-rays. Any person that is having X-ray, if it is a female in childbearing age, need to rule out pregnancy before doing the test. Of course, if you want to fill the cavity of the stomach and the duodenum with the barium, you need to have empty the stomach. You cannot have food, okay, before the test. You need to be MPO. And it's very important that once you swallow this barium will stay in your GI system, okay, for more than 1 week. And you are going to be little by little expelling the barium in the poo, in the feces, and your feces are going to be white. And you need to warn the patient that it's okay. Nevertheless, this barium produces constipation, and it's important to counter the constipation. Just today, one student told me, I have a question how to counter constipation in a patient, and what I said that apply. And the answer is increase fiber, increase liquid, and increase exercise. The three to select is for constipation, do exercise, move. The inactivity produces constipation. Drink liquids, yes, drink liquid, and consume fibers. Doctors can help. Doctor can help with medication. The most commonly used in those patients are stool softeners. Stool softeners. The Docusate is frequently tested because doctors prescribe this for constipation a lot. Docusate. Okay, Docusate can be sodium Docusate or calcium Docusate. The Docusate is the most commonly medication prescribed by doctors for constipation. Yes. So it's frequently tested. It's safe. Can be taken by pregnant women. Is not laxative. Doesn't produce diarrhea. Doesn't dehydrate. Just make the stool soft. And this way, if you have a myocardial infarction or a brain hemorrhage, you don't need to strain. That if you have a baby and you have hemorrhoids, you don't traumatize your hemorrhoid. You understand? In the case of the person that consumes something that makes the constipation, is going to prevent the constipation, the hardening of the feces by the barium, because this is the Docusate. But one student told me recently that she had this medication in her test, Xilium. Xilium, the brand name is Metamucil, is a natural, is over the counter, natural fiber. Is a bulk, what is bulk? No, volume, bulk forming agent. So now the feces are going to be very bulky. And for that reason, the person is going to go to the bathroom more frequent. Is natural, is not a laxative, is fiber, is concentrated fiber, and is healthy. Can be used by any person, any normal person, and can be used by pregnant women. Okay. The other laxatives are strong. are very strong and need to be prescribed. You have the lactulose, that you need to know that because it's the treatment of the high ammonia, but it's also a laxative. It's a sugar that cannot be digested. You have the bisacodyl. Yes, there is a commercial on the TV of bisacodyl. It's a Dulcolax, I think is the name Dulcolax. It's a potent laxative that makes your intestine cry. When the intestine cries, release liquid to the lumen, and this produces like a diarrhea. So you lose water and you lose electrolytes. Yes? The same that with lactulose, you lose water and electrolyte. Okay, but it's very good to lose also ammonia for the people with cirrhosis. Yes. Um, so those are a strong laxative. Okay, that generally are not recommended. While the Docusate and the Ciliums are okay. The other one that is okay is either I forgot one here, MOM, the saline cathartic, the saline laxative. The milk of magnesium can make your intestine cry, can produce, loss of fluids and electrolytes, depending on the dose. And the MOM elevate the magnesium in the blood, so should not be used by certain patients that have high magnesium. Okay, the mineral oil is just a lubricant. Mineral oil is not strong, it's not producing, can be used in pregnancy. And the glycerin suppositories, that is only a lubricant, is when you have something that don't pass easy, you lubricate and then it pass easier. So it is a laxative, glycerin, okay, glycerin suppository. So a brief review of constipation, because I'm noticing on all time, okay, pending the questions are coming out, and I've been a lot of questions about constipation lately, okay, and knowing a little pharmacology, a little knowledge about how to deal, because nurses receive the complaint of constipation frequently from the client, and it's frequently tested. And it's important that when the person swallowed this barium and the abdomen is full of barium, any other test, ultrasound of the bladder, ultrasound of the kidneys, barium enema, endoscopy cannot be done until 1 or 2 weeks later. So if you have a client that have an order of endoscopy, barium swallow, and colonoscopy, the last to be done is the barium swallow. Because if it is done before the other test, will interfere in the other test, while the endoscopies don't interfere in the barium swallow. Barium enema is using the same barium, but is introduced through an enema in the colon to fill the colon with barium, to see if there are tumor, diverticulosis, etc., etc. Can be one of the screening tests for colon cancer when there is any reason for not doing the colonoscopy, because it is to fill the colon with barium. The colon need to be empty, so this client requires preparation. Doctor will order the preparation, requires medication to clean the colon, and the patient need to be MPO or with a clear liquid diet, to prevent residue going to the colon. Uh, the the enema, is administered in since position, and then the patient will have the same problem. It will be pooing barium for a while. The endoscopies, you know that the endoscopy can be through the esophagus, through the mouth, or through the anus. The one that is done through the mouth is called upper GI endoscopy, and the one that is done in the anus is colonoscopy. The upper GI endoscopy is to see the esophagus, the stomach, and the duodenum. So it's an esophagus gastroduodenoscopy. For this test, it's an invasive test, of course. All those tests require consent. Um, the patient need to be MPO because the stomach must be empty to, to see the stomach from inside. And it is tested in which position you place the client, okay, to have an upper GI endoscopy. The answer is left lateral, comfortably, but in left lateral. And the patient will have two medications before the test. One is a sedation, a conscious sedation. So the patient will have midazolam, for example, a benzodiazepine, and as a consequence of this sedation, there are nursing implications. You need to have at hand the antidote of the midazolam, okay, the antidote of the midazolam, which is the benzodiazepine, yes, which is the flumazenil, and it's an Nclex question, flumazenil, okay. And second, this patient cannot drive home because have been sedated, so need to have somebody to transport home. Those are nursing intervention, those are safety, and those are Nclex question. And the second intervention, the second medication is topical local anesthesia spray in the throat. When a person has a topical anesthesia in the throat, the person should not eat or drink after the procedure after the gag reflex return, and is something to have in mind. Uh, this test is not using X-rays. For that reason, a pregnant woman can have an endoscopy. Uh, the endoscopy can have included biopsy. They can take a specimen of the blood. So there is a risk of bleeding and even perforation uh, during or after an endoscopy. And after the patient finishes the endoscopy, you need to have the patient in sedation and bleeding precaution. Sedation precautions include read for aspiration and read for fall and read for accident, okay? And bleeding precaution, well, you know that because it's in you need to monitor if the patient is bleeding. The colonoscopy is to examine the interior of the colon. Sometimes they use a short instrument that only examines the until the sigmoid colon. It's called sigmoidoscopy. But the one that can is longer and examine all the colons is called colonoscopy. The patient need to have a preparation, need to have a preparation, need to have a diet, a clear liquid diet for 24, 48 hours before the test, should avoid red liquids. Why? Because suppose that there is a red liquid, gelatin, cherry gelatin can be consumed, but then the red stuff can appear in the colons and the doctor can think there is blood. Okay, so no red liquids. Was in one question I want you to have that in mind. The why, and the person will have enemas, okay, or polyethylene glycol is the stuff that you drink and then you clean the intestine. The patient will be in Sims position. Remember, the Sims position is also left lateral, but need to have the right leg flexed. The patient will have conscious sedation, okay? So the patient is in safety precautions, cannot drive, etc. And during the procedure, they are going to insufflate the colon with air. So it's normal to have abdominal distension, bloating after the procedure. This procedure, either one, the upper GI endoscopy or the colonoscopy, requires between 30 to 60 minutes to be done, plus the time to recover from the sedation. And again, is a bleeding precaution in case of the stuff. There is a test that is very similar to the upper GI endoscopy, which is the bronchoscopy. Okay, bronchoscopy is the bronchoscopy is the introduction of the endoscopy, but instead of that you have two holes, one side by side. One is the trachea, is anterior. One is the esophagus, that is posterior. But instead of going through the esophagus, it's going through the bronchi. The preparation is the same. It's an invasive procedure. The person is going to be ¿cómo se llama? Need to be NPO, is going to be sedated, is going to have anesthesia in the throat. You know? So it's the same. But then they are going to enter in the trachea. When a, a instrument enters the trachea and the bronchi, the person is going to have limited the the movement of the air. So supplemental oxygen is given to those patients. It is not needed in the upper GI endoscopy necessarily, but there is monitorization always of the saturation of oxygen to see any drop of the oxygenation, and supplemental oxygen is given. Need to understand that it makes sense. And a part of that, you need to know that is a frequent complication when an instrument is introduced in the airway, that this can initiate bronchospasm. Bronchospasm is what happened, for example, to the person with asthma attack. No? So the person doesn't need to be asthmatic, but the manipulation of the end can induce bronchospasm. So albuterol is frequently used. Albuterol is frequently used before and after albuterol, okay, to dilate the bronchi, okay, to deal with this bronchospasm. But the rest is the same. The rest is the same. You know, is the same. Is the same. Somebody has this cellular applied care of a client with a bronchoscopy. The ERCP is a gastrointestinal test that is very common, terribly common, and is commonly tested. In this test, they are going to explore a very complex part of the anatomy that are the tubes, the ducts that come from the liver with the bile, the bag where the bile is stored, which is the gallbladder, the continuation of the tube called common biliary duct that is joined by the tube or duct of the pancreas, the pancreatic duct, yes? And both are going to open to the small intestine, specifically to the duodenum. Okay, so it is the basic anatomy. And just a moment, I'm lost. Okay, here, the duodenum. Okay, and you know that the food is coming here from the stomach. Yeah, the chyme is coming here from the stomach, and when the chyme arrive here, coming from the stomach, immediately a signal is sent to the gallbladder and to the pancreas to spill the bile and the pancreatic juice to mix with the food and initiate the digestion. Okay, this structure, those tubes are frequently affected by diseases. And then diseases can be tumors or could be stones. You can have gallstones that can be, okay, obstructing anything here. Yeah. So the doctor will examine this, introducing an endoscope through the mouth onto the duodenum. This is the endoscope. You see here the endoscope. You see here the endoscope. And it's going to introduce a catheter here in this duct, and it's going to inject backward, retrograde, is going to inject, okay, iodine in those ducts, all those ducts, okay, iodine in all those ducts, okay, and then make an X-ray. And here you have what they see, okay? They see the pancreatic duct here, and they see the common biliary duct, the liver, and the gallbladder, okay? And then they can hear if there is a stone, a gallstone stuck here, is a gallstone that is stuck here, okay? They can even, okay, uh, uh, open this hole here and remove the stones, remove the stones. Okay. Well, this is the ERCP. I explained that for the people that doesn't know that, if there is any person that never heard about that, and it's frequently in the Nclex. So, what implication have the ERCP? It's an endoscopy. So the patient need to be sedated, and the patient has anesthesia in the throat and need to be MPO. The person will have X-ray if it is a woman. Okay, if a woman need to be ruled out pregnancy. If the person have anesthesia in the throat, you know the story of the gag reflex. And if the person is sedated, you know the risk of sedation. And iodine is going to be injected to see the interior of the, so you need to, all the implication of the iodine. What are the implications of iodine? You need to ask directly if the patient is allergic to iodine. In NCLEX, don't ask for shellfish, okay, allergy in those scenarios. NCLEX wants you to be updated. There is no relation between shellfish and iodine allergy. It is a myth that has been discarded many years ago, and it's unacceptable that at this level, after 20 years of being discarded, this myth still, students are repeating because they are using wrong source of information, that there is a relation between shellfish allergy and iodine allergy. You need to ask for iodine allergy, not for shellfish allergy. Of course, you always ask for any kind of allergy: peanuts allergy, food allergy, latex allergy, penicillin allergy. You always ask for any allergy, but specifically for the administration of iodine, you need to ask for iodine allergy. The other stuff that you need to know, that to administer iodine is the patient need to have normal renal function. A creatinine is needed before any test that is using iodine. And you know that if the patient is diabetic and is taking metformin, okay, metformin, it is a medication that doesn't get along with the iodine and need to be discontinued, okay, with anticipation of the administration of iodine. Okay, so it is something that you should know. I'm pretty sure that you know. Okay, those are the precautions with iodine for this test. And of course, after the test, what you can have: a person with risk of bleeding, a risk of perforation, a person that had manipulation of the pancreas has a risk of pancreatitis, and a person that have absent of gag reflex and is sedated. Or try to imagine all the nursing care that this implies. Okay, very good. The GU system test that have been tested. Okay, cystography. Cystitis means urinary bladder, and the cystography is the test to see the urinary bladder. What is done? Well, this patient will have a urinary catheter, Foley catheter, introduced in the bladder, and through this catheter, iodine will be injected in the bladder. So all the implication that has the iodine that I mentioned before. The person is asked to void before the test, because liquid will be introduced, liquid iodine will be introduced with the catheter in the bladder. You need the bladder empty. You don't need urine in the bladder. And then you ask the client to void before the test. The client is going to have a Foley introduced in the urinary bladder, and then they instill the iodine locally. They do X-ray, and then they remove the catheter, and they ask the client to void. And then after voiding, after peeing, they have a new X-ray. Is to see how well the bladder empties alone. You know, and those are the steps of the cystography. Have been tested, and they asked if you need to void, that when you void before, and then after having the catheter filling your bladder, they remove the catheter, and then you need to void and have an x-ray again to see how well you empty the bladder, how much residual is left there. Uh, there is an endoscopy of the urinary bladder. Uh, this is X-ray with iodine. There is an endoscopy of the urinary bladder where they introduce an endoscope inside the urinary bladder, and they can take pieces of tumors, etc. Okay, uh, uh, for a study. When a person is having a cytoscopy, uh, is going to feel after the cytoscopy some burning sensation for the next 24 hours, because you know the trauma in the urethra of the tube introducing this little tube, uh, little duct, and is okay, is expected to have a mild hematuria, mild blood in the urine for the first 24 hours. No bright red blood cells, no bright red, okay, blood. Is going to be a mild hematuria, a mild dysuria, a mild burning sensation, no fever, no intense pain. Because the questions that I see about the cytoscopy are very simple. Just the patient after the cytoscopy having excruciating pain, and what happened? Probably the bladder was perforated, no? And the patient has a peritonitis. So you don't expect that. You don't expect fever, but you just expect a mild hematuria. You expect a mild dysuria. That's it. Um, the other test that is done in the U is the kidneys. In this case, to see the kidneys with X-ray, they need to inject the iodine in the vein, intravenous, and then the iodine travels to the kidneys and fill the kidneys in the process of, of production of the urine, and then you make an X-ray and you see the kidneys. Of course, is the same stuff, is the implication of administering iodine and doing X-rays. For X-rays, pregnancy, for the iodine, we already said, okay, the patient need to have creatinine done. The patient is need to be asked for allergy to iodine and should not be taking metformin. Paracentesis is a procedure that could be diagnostic or can be palliative. The paracentesis is made as a diagnosis when there is need of this liquid for being studied. Uh, Palliative is when the person has cirrhosis and there is an excessive accumulation of liquid in the abdominal cavity that is so much, produces so much tension or pressure that the patient cannot breathe. So one of the questions that I can ask you in the English, okay, the patient has cirrhosis, is going to have a palliative paracentesis because can have a elevation of the diaphragm and cannot breathe well. What position you place the client? So you cannot make the patient adopt the recumbent flat position because it is not going to be tolerated. Need to be with the head of the bed as high as possible. Before the paracentesis, it's very important to ask the client to void, because the site in the abdomen where the patient is going to introduce the needle is near the bladder. So if it is all the abdomen, the doctor is going, this is right, this is left, is going to enter in this area. And then a distended urinary bladder, okay, can be accidentally pierced by the needle that is going to enter there. And this is important. It's a frequent topic. Before the test, before the paracentesis, you weigh the patients and you measure the abdominal girth, and then you do that again after the procedure. Uh, During the procedure, okay, the doctor is going to do anything and you are going to help. But you need to know that in this procedure, they remove an important amount, and very important amount of liquid. And when I say important, can be 2-3 liters. Okay, because it's a palliative procedure. It's a person that is like a, let's see, it's like a hospice procedure. No? And the purpose of the procedure is to make the patient breathe better. This is the desired outcome. But when they remove so much liquid, the patient can develop as a complication hypovolemia. So can present hypotension and even can present acute renal failure. So a classical question is what you monitor after a paracentesis, the blood pressure, urinary output, because you have a situation of hypovolemia, fluid volume deficit, hypovolemic shock, etc., etc. Because usually those patients have cirrhosis. It's not rare that after the paracentesis, then the hepatic encephalopathy, this one that is produced by the ammonia in the blood, the hyperammoniemia, this one that this is a question or just to scare me? No, it's to scare me. Okay, this is the one that produced the asterixis, yes? So the mental status can deteriorate. You need to monitor for asterixis or for altered mental status. Of course, the introduction of a catheter could produce a peritonitis. So you need to see for any sign of fever, abdominal pain, etc. after the procedure. But it is important and it's tested. It is a procedure, the paracentesis, when it's done in tension ascites, that can leave a leak of the liquid after removing the catheter. You understand that the catheter enters in the skin, leave a little hole, and when the catheter is removed, this little hole can allow liquid to live because it's at very high pressure, very high amount inside the abdomen. So it is frequent. It's not desired. It's not expected, but is not reason to consider the situation as an emergency. The other synthesis, amniocentesis, pericardiocentesis, thoracentesis, should not have leak. The only synthesis that could have leak is the paracentesis in patients with ascites. So it's common that this complication is common to happen, but it's not an emergency. So they can ask you what you do if you have a leak of the liquid. Well, you can solve that by yourself. You can take a dressing, and make a bulky dressing and make it, compressive. So apply, a lot of tape, making pressure, and then turn the client lateral to the other side. When you turn the client to the other side, all the liquid and the pressure is going to displace to this side, and then less pressure is going to be over this stuff. If after 12 hours, you see that the leakage continues, then you call the doctor and you explain that has not responded client to this simple intervention that we can do independently. And then the doctor need to come to take a stitch, make a stitch here to close the little hole. Do you understand? Okay, so this is details of the paracentesis that I seen tested in the English. For the liver biopsy, yes, you can have the classical question: in which position you put the patient during the biopsy, and in which position after the biopsy. During the biopsy, this is the position. The patient is going to be recumbent, and the patient will have the right upper extremities behind the head. The patient is conscious with local anesthesia. The procedure is rapid, and it's just a needle that is introduced there with local anesthesia. The problem is that this puncture in the liver could probably, traumatize open blood vessels, and the patient can bleed internally. It can bleed internally. In the moment that the needle is introduced, you need to train the patient to hold the respiration, because you know that the liver goes up and down with the respiration. When you breathe in, the livers move down. When you breathe out, the liver move up. So if the patient continues breathing in the moment that has the needle inside the liver, it is going to produce more trauma. So you need to ask the patient, because it's something that is takes seconds, okay? You need to ask the client to hold the respiration, preferably in expiration, to empty the lungs and to make the lungs separated from the liver. After the procedure, you need to turn the client over the right side and with a roll under the right side, and need to be there for 3 to 5 hours. Doctor will decide how much. And you need to monitor the vital sign because it's a high risk of bleeding after the procedure. Before the procedure, liver function test, no liver function, coagulation test, excuse me, coagulation test must be done because if the patient has a prolonged PT and INR, the patient has any problem of coagulation, then the test cannot be done. For the renal biopsy, again, they are going to ask you in which position you put the patient during the procedure, in which position after the procedure. Both questions are, okay? So again, it's a test that can produce internal bleeding. So during the procedure, the patient needs to be in prone position, face down. After the procedure, the patient will have be in supine position with a pillow or roll under the site of the puncture. And of course, the monitors. Hematuria after a renal biopsy is expected because you expect some bleeding, a mild hematuria, the same as the cytoscopy, a mild bleeding, okay, after the procedure. It is expected. For lumbar puncture, is very important. The position during the procedure need to be in this fetal position. So you need to ask the client. There is no need for a lumbar puncture being NPO. It was tested. You can arrive, God forbid, to the ER with a meningitis, and you can have food, and then they still will practice the lumbar puncture. There is no need of being NPO, okay, before a lumbar tap. Of course, there is no good to have a heavy meal before that because you can be nauseated, etc. But it is not a mandatory requirement to be NPO to have a lumbar puncture. And it's convenient to empty the bladder. Why? Can you imagine to be in this position with the bladder full, with a strong desire to pee? So obviously, now you know that in the majority of the procedure, if they have emptied the bladder before taking the patient to the bed, to the examination table, is logical. The only exception is when they are going to do an ultrasound of the uterus in a woman that is not pregnant or a woman that have less than 20 weeks of gestation. It's important that when a person has a diagnosed the increased pressure here inside the cranium, ICP, cannot have liquid removed from the spine because this liquid communicate. And when you move here, the pressure of the liquid decreases, and then there is a risk of herniation of the brain through the hole that we have in the base of the skull. That's why need to be ruled out intracranial pressure, increased intracranial pressure. A person that is going to have all those details are being based in question that I've been. A person that is going to have a lumbar tap or a diagnose, okay, is going to have a needle introduced in the lumbar spine to collect liquid that bathe this part of the medullary cavity that doesn't have bone marrow, but have all the nerves that are coming to the lower part of the trunk, the pelvis, anus, genitals, bladder, and the lower extremities are present there. They are going to introduce the needle only to pierce the dura mater and obtain the liquid. So there is low risk of piercing the nerves. There is no risk. It is a safe procedure. But if the patient is taking anticoagulant, the procedure can produce a bleeding. And now the bleeding in the here can compress, can make pressure in all the nerves that go to the lower part of the body and produce a paraplegia. So it's a no-no, it's contraindicated to do this procedure in a patient taking anticoagulants. So the classical question is a patient that is taking aspirin, clopidogrel, enoxaparin, and is going to have a lumbar tap. Or a person that just had a lumbar tap and the doctors initiate an anticoagulant. It's contraindicated because it can produce a person to become paralytic for the rest of their life, okay, to become a paraplegic for the rest of the life. And it's a common question. The position is this position, flex of the knees against the chest and flexion of the neck is at the border of the bed. And after the procedure, you know that need to be resting on bed flat without pillow for several hours. Why? Because liquid has been removed from here. Liquid has been removed from here. And the liquid communicate with the head. Okay? This liquid communicate. So now the pressure of the liquid is lower than normal. If you stand up, the pressure of the liquid is low in the brain and is going to pull the meninges and the blood vessel, producing an excruciating headache. You allow the person to be there resting 3, 4, 5 hours, and then the liquid is reproduced, is resynthesized, okay? And this way, the pressure normalizes, and now the patient can get up. That's the rationale of keeping the patient flat without pillows, okay, for a while after the procedure. If the person is going to have the lumbar tap because the suspicious is meningitis, need to be done as soon as possible. Why? Because the antibiotic should be initiated as soon as possible, but the lumbar tap must be done before the antibiotics are initiated, because the importance of obtaining the liquid is to identify which bacteria is producing the meningitis and which antibiotics are, effective to eliminate this bacteria. When there is a meningitis, the liquid is purulent, okay, has increased neutrophils and low glucose. Let's see this question. The nurse in the same day surgery department care for an elderly client after a colonoscopy. What are the risks of a colonoscopy? Which of the following symptoms, if exhibited by the client 1 hour after the procedure, most superlative priority concern the nurse? You have the client complains of fullness and pressure in the abdomen. The client complains of grogginess. This means that is sedated, is sleepy, and thirst. The client complains of lightheadedness and dizziness when sitting up, and the client complains of mild pain and cramping in her abdomen. Okay, what do you think is the most concerning here? If you have a question similar to this in the Nclex.
A.
A,
D as in dog.
D as in dog. Okay, let's analyze that. Okay, when they use the word mild pain and colics, cramping in the abdomen, in a person that was, introduced a tube in all the colon, and especially, that they need, when they introduce the tube, they need to air blow air inside the colon. So now your colon is going to be distended by air, by the gas that was insufflated during the procedure. Having a mild pain, having colics, and experiencing pressure and fullness in the abdomen is expected because probably you are thinking a peritonitis. A peritonitis, okay? No, it's not the most common 1 hour after. After 1 hour of a surgery, what is more common, bleeding or infection? 1 hour after
Bleeding.
a surgery, bleeding, ¿verdad? So, uh, the feeling sedated, confused is expected also. And thirsty, you have been without MPO for so many hours is expected. But what means that a person, a human being, when it is in recumbent position, okay, feels okay. But when the person sits up, so incorporate, feel dizziness. What means that?
Orthostatic hypotension.
Yes, this is the way that patients refers orthostatic hypotension. And remember that orthostatic hypotension is the earliest manifestation of internal bleedings when you don't see the blood, but the person is bleeding, is losing bulimia. While you are in recombinant position, it's okay for the brain because you know enough pressure is reaching. But when you elevate the brain, then the hypovolemia doesn't allow the enough amount of blood reaching the brain, and you feel the dizziness and lightheadedness when you sit up. Guys, this is the way that in Nclex could present an scenario of a person that is bleeding internally. Could be a ulcer in the stomach, could be a woman with an ectopic pregnancy that is bleeding internally, could be any kind of a patient that has surgery and the blood vessel has been bleeding and is bleeding in the abdominal cavity or any part. So it's a person that is losing blood, but is losing the blood internally. In this case, during the colonoscopy, maybe a biopsy or a trauma was produced, and then the person is bleeding internally in the cavity. Still, the blood has not come out. But the problem is that this blood is coming from the veins and arteries of the body, so the person is developing hypovolemia. And when the person has hypovolemia, it is a manifestation that will be felt by the patient. So patients don't call you, nurse, I think I have orthostatic hypotension. No, the, the patient calls you, nurse, I don't know what happened to me, but if I cannot sit up, because each time I sit up, I feel so black, my vision becomes black and feel very dizzy. So this is the way that patients express orthostatic hypotension. You understand? So this is the kind of question that you know that you can have in your English that are a little more difficult because they are exploring. Can you suspect important complication of surgery, procedures, etc.? So don't forget that after surgery and after a procedure, the most common and important complication you need to look for is bleeding, internal bleeding. In surgery, in endoscopies, in biopsies, etc. That you start bleeding, the patient start bleeding internally. And you are not supposed to diagnose the bleeding late when the patient is in shock. You are supposed to suspect this early when the patient is having orthostatic hypotension or an unexplained tachycardia or having a reduced urinary output because activation of the compensatory mechanism that the patient initiates when he's bleeding. This is an example of question that I want you to pay attention because those are the difficult questions in NCLEX. The one that you need to be suspect, to be think a little more, because being sedated is expected after they give you the sedation they give you in that. If they, guys, imagine that you eat black beans, cabbage, avocado, and Brussels sprouts at the same time. How you feel? Full, the abdomen fullness, and with pressure. So it is what happens when they introduce air in the colon. Okay, it's obviously any of you have ever a colonoscopy because you are too young, but you will remember me when you reach your 50s, okay? And having a mild pain, it hurts. This procedure hurts. Okay, for this procedure, they inject you anticholinergic, antispasmodic medication, and they inject you opioids or propofol, etc., so you don't feel the pain. It's painful. It's painful. I remember that they did that the first time they did that to me was with midazolam. That is just a mild sedation. I felt the pain. But it's not the horrible pain. It's a colic. It's when you have a diarrhea, you have a colic. This pain, you know this pain. Everybody knows this pain. You can support this pain. Okay, that's it. A mild pain. Yeah, a cramping in your abdomen. So it is a teaching question. Uh, Another test that is frequently, examined is the catheterism, those vascular or hemodynamic catheterism. Remember that the classical is the entrance in the femoral artery. There are many ports of entry, but we don't need to be doctors. We are nurses, so we go to the most common. So they pierce the femoral artery. It has implication for the leg where the femoral artery is catheterized, because this femoral artery is the only artery of this leg. And two things can happen when an artery is pierced. Can bleed, you need to monitor for bleeding locally, or the artery can develop inside a clot, because when they mesh, when they bother the artery with catheter inside, the artery can react coagulating, and then a clot can grow there. If a clot can grow inside the artery, then there is obstruction of the distal blood flow. The blood flow that needs to go to the leg and to the foot could be impaired, and you need to monitor these two consequences. During this catheterism, you know that usually the iodine contrast is injected. So all the implications of iodine that we already discussed are used. And, ¿cómo se llama? Yes, the iodine stuff, the X-ray, if it's a woman, the piercing. So, but the most commonly question that you have in this is how you care of the site of the puncture. You know that after the procedure, they give you the patient after the procedure, take care of the patient. You are going to be monitored that the blood is flowing normally to the foot. So you are going to be checking the pulses of this extremity, especially the distal pulses, pedal and posterior tibial, and you are comparing those pulses with the other extremity, the one that didn't have the catheterism, and should be normal, should be equal, okay? Take care, because this catheterism is done generally to people that are old and suffer of atherosclerosis, suffer of bad circulation. So it's not rare that it is an 70 years old person that is diabetic and has bad circulation in the lower extremities. So you will notice bilaterally, symmetrically in both feet, you are going to notice low decreased pulses, but need to be equal. It's okay, because the person is old and has all those chronic diseases. But if you notice that in the extremity of the catheter the pulse is weaker or absent in comparison with the other extremities, when you need to call the doctor. Locally, you are going to monitor for blood coming out or for the formation of a lump. If you have a puncture in the skin, if you have a puncture in the skin, the artery is under the skin, and blood is building up, is bleeding there, maybe the blood is not coming out because this puncture is closed by closure mechanism that they use, and then you have a lump. I saw this topic in a question. Remember that in the groin, a part of the artery, you have a nerve, okay, the femoral nerve. What is it? Okay, here. A nerve, a femoral nerve that is at the side of the artery, is at the side of the artery, and they go the same as the artery. They go to the foot, the same as the artery goes to the foot. To the foot. So if you have a hematoma bleeding up here, can compress the nerve, can compress the nerve, and then the patient can experience numbness because compression of the nerve. So it's not expected a numbness in the foot or the side, in the lower extremity or the side of the puncture. And if it is present, you need to suspect a hematoma building up, compressing the nerve. Those are, questions that I seen, okay, in Nclex, where how you suspect complications of this catheterism. You know that to prevent the bleeding, you need to keep the patient with the leg straight. You cannot allow the patient to sit, for example, because when you flex the hip is when the closure mechanism that the doctors leave there can pop out, and then the patient can start bleeding. So need to be, recumbent, okay, with only 10, 15 degrees of elevation, and need to be in this position for some hours, 4 6 hours usually, okay? And during this period, the person need to drink a lot of fluid. Anytime that iodine is injected or a radioactive contrast is injected, because some scans use radioactive contrast, then you need to drink a lot of water, or even can be added some IV to flush the body from this contrast and to pee those contrasts. Those are expected. So you are going to have a patient peeing more than usual because he's drinking more liquid than usual. Okay, so are the main. Remember that those tests is frequently done to go to the coronary arteries and to work in the coronary arteries with angioplasty and stenting. Of the test for tuberculosis, you need to master the details of those tests because are frequently, in the question, in the English. You know that they have different names. The best known is PPD, that stands for purified protein derivate, but you don't need to know that. But also can be called tuberculin skin test, and it's the same. But also can be called Mantoux test, because the guy that they described the test, and it's the same. You know that it is a screening test. It's to early diagnose tuberculosis. Okay, it's a screening test, especially oriented for asymptomatic people that don't have symptoms. Yep. And it is done not to everybody. It is done to people at risk. So you need to have an idea of which people are at risk of tuberculosis and requires the PPD. You know that you don't do, for example, mammography to girls. Why? Because they are not at risk. You start doing the mammography after 40 years. Before, you are not at risk in the general population. Yes. So you don't do PPD to people that are not at risk of developing tuberculosis. You do that to people at risk. So you can be tested who are people at risk. The first to know that we, healthcare workers, are people at risk. Immigrants, people that have been here for less than 5 years, are people at risk. People that have immune deficiencies, people that are taking immune suppressors, prednisone, chemotherapy, immune suppressor for transplant, immune suppressor for lupus, for those immune suppressors are people at risk. People that have HIV or AIDS are people at risk. People that have malnutrition, because the malnutrition produces, immune suppression. Like, for example, alcoholics, for example, homeless. ¿Entiende? Those are people at risk. When you have a lot of people gather in a long-term care facility, in nursing homes, when you have people gather in a jail, those are people at risk. They're saying that people have been in contact in some way with people with tuberculosis. You are in an airplane, and then later, 1 week later, they diagnosed tuberculosis with one of the passengers of these airplanes. Then the Department of Health will contact all the list of passengers to do PPD. Do you understand? Uh, those are examples of people that are at risk. When you do a PPD, you do an intradermal injection of 0.1 milliliter of the purified protein purified protein derivate PPD, and read the site 48 2 days, 48 to 72 3 days, 2 to 3 days after the test. And you are going to look for induration, for a wheal, okay, for a lump. You don't pay attention to the erythema. And then if there is a wheal or a lump, you need to measure carefully, measure that with a ruler in millimeters. And you are going to make interpretation of this measurement. Um, when you have a person at risk, and we already determined which are the person at risk, and those are the person that should have a PPD regularly done as a screening test, is considered that 10 or more millimeters is positive. So person at risk, 10 millimeters or more is positive. It applies for adults and children. But if the person is immune suppressed, somebody in chemo, somebody in high doses of prednisone, somebody that has a transplant, kidney transplant is receiving immune suppressor, somebody that is injecting adalimumab, etc., immune suppressed, HIV with AIDS, immune suppressed, yes? 5 millimeter or more is considered positive. And you need to understand that it's different. Okay. So if you have a PPD test, and the result is 7 millimeters, it is what you do next. Consider it positive, consider it negative, or ask if the person is immune suppressed. The answer is ask. Assess if the person is immune suppressed. If the person is immune suppressed, 7 millimeter is positive. If the person is immune competent, 7 millimeter is negative. You understand? 7 millimeter is negative in a person at risk but immune competent. If the person is at risk and is immune suppressed, because any immune suppressed is at risk, 7 millimeters is positive. So two different interpretation of the same test depending if the person is immune competent or immune suppressed. For if the test, which is not common, is done to a person who is not at risk, positive is considered 15 or more. But you know that it is not done frequently. It's just a curiosity because the test is done to person at risk. That's why these two interpretations are the most important. By the way, if a person has been in close contact is living with a person with active tuberculosis, when the active tuberculosis is diagnosed, the person that lives with the active tuberculosis is going to be tested also. And 5 is positive, even if the person is immune competent. It is, a variation and a specific, case. Okay, so when you have a person that the PPD is positive, you say, okay, you have been in contact with the bacteria because your body knows the bacteria. This is the interpretation. You has been in contact, you have been exposed to the bacteria, and the bacteria is inside you. Okay? But it doesn't mean that you are sick. The only meaning is that you have been exposed to the bacteria. You has been, you have the bacteria inside you. Is what means a positive PPD. So now you know that, okay? You know that. Now you need to determine, is this person having the bacteria sleeping or the bacteria awaking? If the bacteria is sleeping, okay, because if the PPD is positive, we assume that you have the bacteria. If the bacteria is sleeping, we call that latent tuberculosis. If the bacteria is awakened, is active, we call it active tuberculosis. The latent tuberculosis is asymptomatic. Is if the person has no fever, has no loss of weight loss, has nothing, is asymptomatic. If the bacteria is active, the person probably is symptomatic, symptomatic, okay, symptomatic, yes, symptomatic. If the bacteria is latent, the patient is non-contagious, is not catching, no contagious, so cannot pass tuberculosis. If the bacteria is active, the patient is yes contagious, okay? If the bacteria is latent, the lung X-ray is normal. If the bacteria is active, okay, the X-ray is abnormal. If the bacteria is latent, the sputum doesn't show the bacteria. The test, important, you need to know the name of the test. The test to see the bacteria in the sputum is called acid fast bacilli, AFB. Acid, like vinegar acid. Fast, like rapid, bacilli. The bacteria that produces tuberculosis is a bacilla, is a bacillus. Okay, it's a bacillus. Okay, the TB bacillus, the Mycobacterium tuberculosis. Okay, Mycobacterium tuberculosis is a bacillus. Yes, acid fast bacilli is negative. No AFB in the sputum. If the person has active tuberculosis, the acid fast bacilli is positive, and this is the gold standard. This is the last word. This is the confirmation that the patient, okay, has tuberculosis. If a person has an active tuberculosis, need to be placed in isolation, in airborne isolation. If the person has latent tuberculosis, doesn't need isolation, can be at home. No isolation, no isolation. So this is the consequences of having a positive PPD. Is it true that a person that is coming from countries of the third world and receive a vaccine that is only administered in the third world, is not administered in the first world, it's not administered in Europe, it's not administered in North America, it's not administered in Japan, in the first world, the developed countries. That is called the vaccine. This vaccine is administered only in the third world. It's called the vaccine or the bacilli of Calmette, getting. Acronym BCG. Is it true that a person that has received this vaccine recently could have a positive PPD? Yes. But we don't know if the PPD is positive because received the vaccine or because has the bacilli sleeping, because this person is coming from the third world. In the third world, the tuberculosis is frequent. And we cannot differentiate if the positivity of the PPD is because had recently the vaccine or because acquired the bacilli in the third world, because it is said that more than 50% of the population of a country of the third world has the bacteria, okay, has the bacteria. And this bacteria generally is acquired and the patient is asymptomatic and maybe never will develop the tuberculosis. When a person that is carrying the sleeping bacteria has latent tuberculosis, develop tuberculosis when the defenses, okay, drop, when there is immune suppression. And this is the interpretation of the tuberculosis. What is done with the latent tuberculosis here in America? It is recommended, seriously recommended, to have a treatment to clean the body of the bacteria. And this treatment generally is done with isoniazid. Isoniazid is the best antibiotic for tuberculosis. Okay, and is given to clean the body when you have latent tuberculosis. Can you refuse the treatment? Yes. Why? Because you are not contagious. You don't have active tuberculosis, but it's highly recommended. When the person has active tuberculosis, need to be isolated because it's a risk for the population. Okay, need to be in airborne isolation, and should be receive a combination of 3 or 4 antibiotics that are going to be maintained, okay, for at least 9 months, and is going to be supervised. But this person, when 3 sputum are negative for acid fast bacilli, is taken out of isolation and sent home to have a normal life, can go to work, doesn't need more isolation. When 3 sputums are already negative in the active tuberculosis after initiated treatment, the patient is not contagious anymore and is sent home to continue the treatment at home, okay, but without any kind of precaution because the patient is not contagious anymore. Okay, so that's it. Another question has been English. You have a person very, very sick, has AIDS, is severely immune suppressed, and has all the symptoms of TB, all the symptoms of tuberculosis, has AIDS, very immune suppressed, but with all the symptoms of tuberculosis, and the PPD is negative. This rule out, this discard the possibility of having acute tuberculosis? No. When the person is too much immune suppressed, the PPD can be a false, not true, false negative. A negative PPD cannot rule out active tuberculosis, especially in people with severe immune suppression. Is another concept that you need to know to have about the PPD. Okay, very good. I think that this information is enough to deal well with questions of PPD and tuberculosis. In relation with perioperative care, which is another topic that can be, remember that before surgery, you need to be very careful to rule out latex allergy. And you know everything about latex allergy. I'm pretty sure that you know, but it's refresh that because it's frequently tested. You are expected in your admission assessment to make the proper questions to rule out the possibility of latex allergy. You are going to ask about latex allergy directly, but also you can exchange the word latex for rubber because rubber and latex is the same. Okay, if you are allergic to rubber balloons, to rubber toys, to rubber flip flops, okay, is the same of being allergic to latex. These are being tested, okay? So anyone that doesn't know that, you need to know that. Second, you could not know that you are allergic to latex, but you know that you are allergic to tropical fruits like bananas, avocados, kiwi, papaya, pineapples. Generally, they're tropical fruits. Those clients that are allergic to those fruits frequently are already allergic to latex and must be reported to the physician, to the surgical team. And people that are born with a malformation in the lumbar spine called spina bifida that can be overt. In those cases, the patient is born with a myelomeningocele or meningocele, those tumors that can, by a malformation, being in the low back of newborns, or can be hidden, can be occulta, okay, occulta. That is, people that have a normal back, no tumor there, but in the X-ray, you can see a spina bifida in the X-ray. It is a very mild spina bifida. You can have in those patients with spina bifida occulta a mole in the lower back, okay, that could have hair, a tuft of hair is a possibility or not. And so people with spina bifida, and also people that have in the past multiple surgery. There are people that have for any reason many surgeries, and having history of many surgeries can make you become allergic to latex. The other stuff that you need to rule out in the assessment is malignant hyperthermia. Remember that it tends to run in family, and asking their family history is important. I hope that you master all the details about informed consent. I already make, not too long away, a review of this topic that is super important. But don't forget that patients going to surgery will receive pre-medication, pre-anesthesia medication that could include substances, medication that can alter the mind. And for that reason, you need to take care of asking the client to sign the consent before receiving those medications. And in relation with the incentive spirometer, remember that the purpose is to suck air through the device, not to blow. It is not a trumpet. This is not a whistle. It is an instrument to psychologically stimulate the client to take deep breath, suck air through the mouthpiece, and while the patient is sucking air, the patient will see the elevation of this marker, of this diaphragm elevating, and this is going to motivate psychologically to breathe in each time more and more to expand the lungs, okay? And you know that this is going to prevent atelectasis and complications of the hypoventilation that have those patients that have surgery. It should be done 6 to 10 times per hour, and could be combined with cough. But when the patient is coughing, should be do splinting of the wound with a pillow. And also you need to teach the clients about the PCA, or patient-controlled analgesia, which is a device that the patient can push to deliver pain medication when they have pain. Teach the patient that only the patient, he or she, can push this button. The family member, the nurse, any other person cannot push that. And teach the client that when they start experiencing pain, they can push the button early. Don't wait until the pain is too strong, because then it's more difficult to relieve. And assure the client that is no risk of overdosing because they push more than once, because once the patient pushes and a dose is delivered, the machine enters in a lockout period in which the more medication is not administered, even if the patient continues pushing. Remember that before surgery, blood pressure medication usually is taken with a sip of water, and still the patient is MPO. Remember that medication that inhibit coagulation should be reported, because usually are discontinued before the surgery. If the person is taking glucocorticoids before the surgery, the glucocorticoids must be kept, and the dose could be increased. There is a possibility of passing the glucocorticoid from oral to parenteral. Is okay, no problem. What cannot be done is reduce the dose or discontinue the medication. Remember that diabetic clients cannot go to surgery with NPH insulin or glargine insulin, only with regular insulin, and cannot go to surgery with metformin or glipizide, sulfonylureas, or any oral anti-hypoglycemic medication. Remember to remove anything that can be in the mouth of the eye of the clients, except the regular eyeglasses and the hearing aids are left. They go to surgery with them. They are removed after the patient is out. Remember that prophylactic antibiotics are given 1 hour before surgery. if the time of the surgery is changed, remember that you need to change the moment of the prophylactic antibiotic that must be given exactly 1 hour before the surgery, before the incision. Remember that DVTs are prevented with TED stocking and the sequential compression device, also with early ambulation. Remember that for the TED stocking, you need to measure the length of the legs and the circumference of the calf and the thigh, and then you go to a chart that gives you the correct size. Remember that to apply the TED stocking, TED stands for thromboembolic deterrent stocking or socks. No, you need to put that when the patient is on bed. You cannot allow the patient to lower the legs to put this. And then you can, apply a little body powder, and then you roll the sock, the stocking, inside out, the same way that women know how to put those stuff, and then you pull this up until the thigh without leaving any kind of wrinkles and without rolling the top, because would be acting as a tourniquet. There is a hole in the string, the distal string, that should be left in the sole. This stocking is used all time, when on bed and when ambulating. All time, while on bed and while ambulating. But every shift, you should remove the stocking to check the skin, to provide hygiene, and then you place that again while the patient is on bed, is resting. Yes? And yes, you can check this top with the hole that you have here, the circulation there. It is the most important. This is frequently tested. Okay, how it is done. Can the CNA put that? Yes. After you, the first time that is put by you, because you need to measure and determine the size. The assessment of the skin is made by you, but the CNA can put that, yes, and the patient can be taught to put him or herself the TEDs. The sequential compression device are used only when the patient is on bed or sitting, not when the patient is walking. The SCDs need to be left, a space between the cuff and the skin. 2 fingers should enter flat between the cuff and the skin. And you can remove them for a skin check, no problem. And if the patient has already DVT, you cannot put neither the TED stocking or the SCD, because it's going to pump the clot for the lungs. Remember that the perioperative complications of the malignant hyperthermia that are diagnosed because the patient developed fever during the surgery or immediately after the surgery, and muscle rigidity. The medication dantrolene should be available to treat this malignant hyperthermia. The patient is at risk of developing respiratory complications, atelectasis, pneumonia, hypoxemia, and for that reason, this therapy of incentive spirometer, cough, splinting, early ambulation are used. We already discussed that the immediate complication of the surgery is hemorrhage. Remember that the blood is a liquid. So you can have a person on bed after surgery and you don't see the blood. But if you introduce your hand with glove hope behind the clients, you can find the blood, because the blood can pull behind the client. It's a common question in the Nclex. Okay, you need to know what is this term, knee gauge. Do you see how I put this bed? There is a clinical bed that this part that is behind the knee can be elevated. This is called knee gauge. Okay, knee gauge. This is caca. No. And placing pillow under the knee, in the posterior part of the knee. This part is called popliteal area. Okay, but you have the hole that you have behind your knee is called the popliteal area. There you have a deep vein that is easily compressed if you put a pillow there or you elevate the knee gauge. Caca, no, don't do that. Yesterday, I learned that somebody had in their question something that I, as a CNA, learned. The heel is the part of the foot that have high risk of developing a pressure ulcer when the patient is on bed. When the patient, this is the ¿cómo se llama? The mattress, yes? So here you have bone and skin. So you have here a bony prominence, and this is a perfect site to develop a scar, a pressure ulcer. So the intervention is not to put a pillow here. Don't put a pillow here. No caca. No. What you need to do is, just a moment, is to put a pillow here, okay, a pillow here. So now the heel is floating, is separated from the mattress. It is called off-loaded heel, okay? So no pillow heel in the popliteal area, just pillow heel in behind the leg to have the heel floating, okay? Okay. Remember that you, after surgery, are not going to allow the client to eat until the bowel sounds return or the patient pass gas. And remember that there is a risk of wound dehiscence or wound evisceration days after the surgery, that when you have a wound dehiscence or evisceration, the first to do is to move the patient down to a low Fowler position, so a low elevation of the head, and the knees flex. So the patient need to flex the legs. Give antiemetic or antitussive if the patient is coughing or gagging, and cover, after you put the patient in this position, cover the wound with a sterile dressing, moist with normal saline, and prepare for surgery, okay? So those are some topics of review of content that I want to review with you today to reinforce your contact knowledge for the test. Do you have any question? No? You okay? Okay, in that case, well, see you next time.
Thank you, Professor.
Good night.
Thank you. Good night.
Thank you so much.
Thank you so much.
Thank you. Let me
Thank
collect the attendance, and that's it. Okay. Okay, download. And that's it. Close.